one of the most volatile chapter, that is calcium metabolism. But it is a very critical also. We have tried to make it a brief, pertinent and to the point so that you can recapitulate this and reproduce this in your question paper. There are many MCQ questions arises from this chapter. So be very careful. Parathyroid gland and calcium metabolism. Basics of how many parathyroid glands are there? 4. Both sides, upper and lower. 10% people have 5, 5% have 3. Main cell is chief cells which secretes parathyroid hormone. Oxyphil cells are there but functions are unclear. Blood supply is from inferior thyroid artery and can be damaged during thyroid surgery, leading to hypoparathyroidism. Calcium is a very important for our body. Normal total is 8.5 to 10.5 milligram per dl. And ionized calcium is 4.5 to 5.6, and this is the active form. Why this calcium is critical? Anything, any contraction. Have you read the action potential during your physiology classes? Which part of the action potential is dependent on calcium? So, initiation of any action potential starts with calcium interaction. So, calcium is very important for muscle contraction, nerve conduction, blood clotting, enzyme function, bone structure. Even 0.5 milligram per dl drop can cause tetany. Madam, body stores 99% of calcium is in the bone as hydroxyapatite. Only 1% is in blood and soft tissue, but that 1% is strictly controlled. So most of the calcium in our body is in store, and that is in a very dynamic process. Every time there is osteoblastic activity and osteoclastic activity, this is not a static one. So, to maintain the blood calcium around 1%, the bone is all time remodulating with some activities which is rank L, and another is OPG. This both two actions are there acting each other to maintain the calcium level. To maintain the calcium balance, 3 hormones are there. Parathyroid hormone, source is chief cells. What is the trigger of releasing of the parathyroid hormone? That is low ionized calcium. Main action is increase of the bone resorption and increase in the kidney calcium reabsorptions and increase in the phosphate excretion. So these are actually, this is in the tabulated form, but last day also I was to mention it that I cannot make the tabulations. I am very poor in Excel. So I have mentioned like this, that hormone, parathyroid, source chief cell, trigger is low ionized calcium, main actions to increase bone and resorption, increase kidney calcium reabsorptions so that calcium comes into blood, and increase in the phosphate excretion. So there will be hypophosphatemia. Effect on the blood calcium, there is an increased vitamin D activation in the kidney. There will be increase in the blood calcium level, and there is a reductions in the phosphate level. So there will be high. The effect of parathyroid is to increase the calcium in the blood and reduce the phosphate. Next is calcitriol. Calcitriol is 125 OH vitamin D. In kidney, it is the source is kidney via 1 alpha hydroxylase. The effect is whenever there is high pH, low phosphate, low calcium, it causes increase in the gut calcium and phosphate absorption, and bone resorptions increase with PTH. So this is the only part of vitamin D without which whatever calcium you take in milk or paneer or anything, it will not get absorbed. So this calcitriol is the main part which will help your absorption of calcium from the gut. Third is calcitonin. Calcitonin is source is thyroid C cells. Whenever there is high calcium, this will be triggered. Main action is reductions of the bone resorption, increase in the calcium excretion. So there will be reductions of the blood calcium, though it is a very minor role in humans. So what is the key sensor? This is CASR, calcium sensing receptor on parathyroid cells. High calcium instigates CASR activation and parathormone secretion suppressed. Low calcium, parathormone release in minutes. So this is the cycle, positive feedback cycle. Parathormone is the master regulator. When calcium falls, PTH acts within seconds to minutes. In bone, it binds osteoblasts, increase in rank L. This is a nuclear activator. We know that there are some ligands. This activates osteoclasts. Calcium and phosphate released from the bone, fast effect of osteocytic osteolysis, slow effects from osteoclast. In kidney, it will increase the calcium reabsorptions in distal tubule. You note this distal tubule. So, one important drug acting on the distal tubule, Furosemide. So, it will actively compete with that. Keep it in mind. So, when there is hypercalcemia, we will not give Lasix because that will impede the calcium excretion. So, there will be more hypercalcemia. Keeps calcium in the blood. Now, phosphate reduction, reabsorption in the proximal tubule, phosphaturia prevents calcium phosphate from precipitating when calcium rises. Increase in the 1 alpha hydroxylase, there will be more active vitamin D made. And in gut, indirect, increased calcitriol from kidney, intestinal calcium absorption via TRPV6 channels. Anyway, parathormone increase, calcium decrease, phosphate decrease. This is why primary hyperparathyroidism, there is a high calcium and low phosphate. So, this is the basic parathormone. The functions of parathormone, basically what we point out, parathormone will increase in the calcium, decrease in the phosphate. Okay. And another part is vitamin D axis. What is the role of sunlight in metabolism of vitamin D? Which part of the sunlight? Ultraviolet B. What is ultraviolet B? What is the range of the ultraviolet B? These are the MCQ points I am telling you every time. Keep it in mind. What is ultraviolet B? What is the range? From which range to what range it is ultraviolet B? What is ultraviolet A? This you read. Until you read it that minutely, you will not recapitulate it. And what is the angle of sunlight which will stimulate? At which time of the day sunlight will help formation of the vitamin D? Any idea? This ultraviolet B, when it is coming at the angle of 30 to 45 degree, that is the time when it gets activated. So, in the evening it is not helpful, but in the morning it is helpful. So, if this is the thing, when you will advise your patient to go into sunlight, when they will go out? In the noon or in the morning, early morning or evening? So, that is the thing you have to know very meticulously, and that is the depth of your knowledge should go. Skin ultraviolet B, which convert 7-dihydrocholesterol to cholecalciferol D3. This D3 will convert from D3 to 25 OHD. This is calcidiol. And the vitamin D3 we measure by blood is this, calcidiol. Calcidiol is what we measure. And in kidney, this 25 OHD is converted to 125 OHD, that is calcitriol via 1-alpha hydroxylase. This step needs parathormone. So, without parathormone, even if you take vitamin D, kidney won't activate it well. Gut won't absorb calcium and there will be hypocalcemia. So, without parathormone, vitamin D has got no role in maintaining the calcium. Understood? The quick correlation. Here we will discuss primary hyperparathyroidism, secondary hyperparathyroidism, hypoparathyroidism and vitamin D deficiency. Just again, sorry, this should be in a tabulation form for easy. Please make it in a tabulated form yourself. This is the condition. This is the parathormone status, calcium status, phosphate status, vitamin D status and alkaline phosphatase. In primary hyperparathyroidism, what we will see that PTH will increase. Same primary parathyroidism problem is the parathyroid gland. So, parathyroid will be increased, primary hyperparathyroidism. Calcium will increase, phosphate will low, vitamin D normal or low, and alkaline phosphatase, if there is other bone disease, then only this alkaline phosphatase will go up in bone disease. In secondary hyperparathyroidism, that is in CKD, parathyroid will increase calcium both either hypo or normal, phosphate will go up, vitamin D will go down, and alkaline phosphatase go up. Hypoparathyroidism, what will happen? There will be reductions in the parathyroid hormone. Calcium will go down, phosphate will go up, vitamin D will be less than active, and alkaline phosphatase will be normal. And what will in vitamin D deficiency? There will be no change in the parathyroid level. There is an increase in the calcium level, decrease in the phosphate level or normal. Vitamin D will go low and alkaline phosphatase may go up. Now, what are the symptoms of calcium imbalance? In hypercalcemia, incidence of stones go up. Calcium deposits, what are the different type of calcifications? You know that? When there is a dead tissue or in a fracture healing stage, calcifications goes on. So there are some metastatic calcification, there is calcifications on the dead tissue. So calcifications, whenever there is a increase in calcium is there, that will make up stones in different parts of the body. There are different types of stone, I will not discuss now. Bones will be depositions of calcium in the bone, groans, moans and thrones, that is kidney stones, bone pain, abdominal pain, psychiatric symptoms and polyuria. And in hypocalcemia, to start with, perioral numbness, Kostex sign, Trousseau's sign, tetany, seizures and prolonged QT. You go through this sign, how to demonstrate, because in clinics if you come, then we can demonstrate in a patient how to examine this. Workup. Correcting calcium for albumin, that's the first step. Calcium bounds to albumin. 40% of bulk calcium is bound to albumin. If albumin is low, total calcium looks falsely low even if ionized calcium is normal. So corrected formula, corrected calcium milligram per dl is equal to measured calcium plus 0.8 times into 4 by the 4 minus albumin gram per dl. It is like this, I am telling you. Example, if calcium is 7.8 and albumin is 2.5, then the corrected calcium will be 7.8 plus 1.8 is equal to 9. Actually, it is normal. So, 7.8 with hypoalbuminemia, don't declare it as a hypocalcemia. First, you check the albumin level. When to check ionized calcium? If albumin is abnormal, pH is abnormal, or patient symptomatic despite normal corrected calcium, ionized calcium is the gold standard. Usually we don't measure it. Ionized calcium we measure in what setting? In ICU setting. In ABG, have you seen anyone at the ABG report? Arterial blood gas report? There you will see that calcium high. So that calcium is this one, ionized calcium. Ionized calcium we measure only there when there is a pH abnormal, albumin abnormal, or patient is symptomatic. If using ionized calcium or patient in paraproteins or multiple myeloma, they bind calcium too. In that case, you need not correct. Hyperparathyroidism workup. we will do first whether the calcium is parathyroid or dependent. We will order the test: calcium, albumin, phosphate, parathyroid hormone, vitamin D, creatinine. And then we will discuss whether it is primary, secondary or tertiary. Again, type primary, calcium level increase in primary, parathyroid increase, phosphate inappropriately, this will be parathyroid or inappropriately abnormal, phosphate will be low, vitamin D normal or low, urine calcium increased. The primarily cause may be single adenoma. So what are the commonest cause of primary hyperparathyroidism? Is adenoma, tumor, parathyroid tumor. Parathyroid tumor is the commonest cause of primary hyperparathyroidism. Secondary, type of secondary: calcium low or normal, parathyroid high, PTH high, phosphate if low, if vitamin D deficiency, and common cause of secondary parathyroidism is CKD, vitamin D deficiency and malabsorption. Malabsorption syndrome impairs the absorption of the calcium in the body. So secondary, the cause of secondary is CKD, vitamin D and malabsorption. What is tertiary? In tertiary, we will get increase in the calcium, increase in the phosphate, here increase in the parathyroid, vitamin D low or normal, and urine calcium go up. This is long-standing secondary or autonomous glands leads to this tertiary hyperparathyroidism. This is a short note. This is FHH. Familial Hypocalciuric Hypercalcemia. What happens here? Calcium mildly increase, parathyroid normal or mildly increase, phosphate normal, vitamin D normal. There will be decrease in the urine calcium. So this is the most hypocalciuric hypercalcemia. So if urine is not being excreted, for that reason calcium is there, high calcium is there in the blood. So this is a familial condition. This familial hypocalciuric hypercalcemia. This is a benign condition. There is a receptor mutation and here we don't need to do anything. Now, primary hyperparathyroidism confirmed. Then what we will do? We have diagnosed it is a primary hyperparathyroidism, but by blood report. Then our main suspicion is that there is a adenoma in the parathyroid gland. What will we do? We will do bone DEXA scan. What we will find? Classic loss as distal 1/3 of radius. X-ray subperiosteal resorption. Mind this word, subperiosteal resorption. Again MCQ. Where we will get it? What we will get in the kidneys? EGFR, urine calcium 24 hours, urine ultrasound for stones or nephrocalcinosis. High effect of high calcium in the blood. And multiple endocrine neoplasia we have to rule out. Check for prolactin, gastrin, family treatment if more than 30 years or multi-gland. Localization only if surgery is planned. First line, this is a systemic scan, neck you ultrasound. If concordant, good. If discordant, again 4D CT, PET, this sort of thing. But one thing, unlike suspicions of thyroid nodule, we will never do this fine needle aspiration. If we suspect there is a nodule in the parathyroid gland, we will never do fine needle aspiration. Why? Can cause parathyromatosis. So this is a very important MCQ again. The choice will be, we will do FNAC. This will be the wrong answer. Surgical indications, if calcium more than 1 milligram per DL above normal, less than 40 years, stones, osteoporosis, EGFR less than 60, 24 hours urine calcium more than 400 or symptomatic. Hypoparathyroidism workshop. Classic lab test. Low calcium, high phosphate, low parathyroid or inappropriately normal parathyroid. Step 1, find the cause. Take a history whether there is a history of surgery in the neck. Post-surgical, 75% of cases. Check recent thyroid, parathyroid, carotid surgery. Autoimmune, isolated or APS1. We have to see anti-CSR antibodies. Look for candidiasis or additions. What happens in additions? What is addition? Any idea? Any idea? Adrenergic crisis, adrenal failure of adrenal gland. Genetic DiGeorge syndrome, in that case cardiac defects, thymic aplasia, facial features. Infiltrative, iron overload, Wilson's metastasis, and magnesium depletion. Magnesium depletions they will lead in the PTH secretions and action impaired. Always check magnesium in hypocalcemia. This is a subtle changes of magnesium, means lot for our body. Whenever we suspect hypocalcemia, if we without checking magnesium, if we give calcium, that will be detrimental. Key surgical landmarks and danger zones. We have to check for it. Access the complications. QT prolongations, tetany, seizures. If there is, then we have to give calcium gluconate as early as possible. And if there is chronic visual ganglia calcification, CT scan, cataracts and dental issues. Management basics, calcium carbonate or citrate, 1 to 3 gram elemental calcium per day, plus vitamin D. Target calcium low normal 8 to 8.5 to avoid hypercalciuria. Thiazides to lower urine calcium. Parathyroid 1/84 natpara if refractory. Parathyroid supplementation is very, very costly. So quick differentiation table, what we have primary hyperparathyroidism and hyperparathyroidism. Calcium, primary high, hypo low. Phosphate, primary low, hypo high. Parathyroid, high, hypo low. Urine calcium, either high or normal, but in hypo there is low. Symptom, stone, bones, groans. In hyperparathyroidism and hyperparathyroidism, tetany, bostox and this troseous sign. Vitamin D, we want vitamin D more than 20 to avoid secondary hypoparathyroidism. Give 125 OSD because 1 alpha hydroxylase needs parathyroid. So This is the quick differentiation table. Now, three short notes separately: osteoporosis, osteomalacia, and rickets. These are the important bone disease we come across in different phases of life. Osteoporosis, osteomalacia, and rickets. We have to know the basic differences between these three. All three cause weak bones, but the pathology is totally different. Quantity versus quality versus mineralization defect. Code definition: disease, osteoporosis. What's wrong? Reduced bone mass, but normal mineralization, less bone overall. So bone mass is reduced. Mineralization is normal in osteoporosis. Bone biopsy: thin trabeculae, normal osteoid bone ratio, mostly in adults, elderly, and postmenopausal. The huge chapter of osteoporosis bring down to one line. So please keep it in mind, the differences. Osteomalacia, what's wrong? Decrease in mineral of osteoids, normal bone mass but soft. In biopsy, increase in osteoid seams, wide unmineralized matrix found in adults. And what is rickets? This is osteomalacia, means reductions of the mineralization plus growth plate defect. So this is osteomalacia plus growth plate defect found in kids. Same as osteomalacia, widened disorganized growth plates, children with open physis. So these three pertinent point: what's wrong, bone biopsy, and age group. These are the differences. Key: osteoporosis is not enough bone. Osteomalacia, rickets, enough bone matrix but is not calcified. For that reason, it is soft or rubbery. Pathophysiology and causes: osteoporosis, there is imbalance between bone resorptions and formation. At the age of 0, bone formation starts. That is a upgrowth. Increase formation, less resorption. At the age of 40, balanced. After 40, reverse occurs. This all things is maintained by some hormones. One of the important hormone is thyroid hormone. So you see, this small gland here controls almost total bone metabolism, calcium metabolism, by thyroid hormone, parathyroid hormone, calcitonin. Keep it in mind. Primary osteoporosis is age-related, postmenopausal, less estrogen. There is a rankle increase, osteoclast formation. Secondary, due to steroids, hyperparathyroidism, hyperthyroidism, alcohol, smoking, anorexia, PPIs. PPI means is protein pump inhibitors. Many of us are used to take protein pump inhibitors very frequently. With this slighted abnormality in the digestion system, first thing we advise, take a Pan-D or you take a Rablet, anything like that. But you keep it in mind, this leads to osteoporosis. SSRI, celiac disease, myeloma, CKD. Lab, what we will find? Calcium, phosphate, parathyroid, vitamin D will be normal. Alkaline phosphatase will be normal unless there is a fracture. So in osteoporosis patient, if there is an increase in alkaline phosphatase, then we have to suspect there might be some subtle fracture is there. Osteomalacia or rickets, the problem is not enough calcium phosphate available to mineralize the osteoid. Vitamin D deficiency, reduced gut calcium absorption, reduced calcium, increased parathyroid, that is the increased bone resorption, low phosphate, phosphate wasting. This is X-linked hypophosphatemic rickets. This is a genetic condition where phosphate is very low. Fanconi syndrome, TIO, hormone-induced osteomalacia. Here phosphate is low, so there will be osteomalacia or rickets. And mineralization defects, hypophosphatasia, CKD, aluminum toxicity. Labs will found calcium low or normal, phosphate low, alkaline phosphatase high. Parathyroid high, vitamin D low, and if vitamin D deficiency, in that case only we will find vitamin D low. So you see here alkaline phosphatase is high. Clinical or X-ray clues, osteoporosis, there will be pain, usually none until fracture. In osteomalacia, there will be diffuse bone pain, muscle weakness. In rickets, same like osteomalacia, only there will be leg bowing and delayed walking. This is in the kids. Fracture type, in osteoporosis, wrist, hip, vertebra, low trauma. In osteomalacia, pseudo fractures or loser zones. Again, loser zones is a short note, keep it in mind. And in rickets, there will be green stick fractures. What is green stick fracture? Every point mentioned here is very important, because if you go through any Harrison's or Davidson, you will see the calcium metabolism is a huge chapter. That has been reduced to this. So only select important terminologies have been used, and every terminology has got some significance. Deformity, osteoporosis, there will be kyphosis, Dowager hump. Osteomalacia, there is no deformity usually, but in rickets, there will be board legs, rachis rosary, and craniotabes. These are the deformity in rickets. X-ray, there will be increase in the bone density and cortical thinning. In osteomalacia, loser zones, reductions in the cortex, loss of lamina dura, and rickets, cupping or fraying of metaphyses, widened physes. Muscle, osteoporosis will be normal. In osteomalacia, proximal weakness, waddling gait. What is waddling gait? Any idea? Yes, duck. And in rickets, same plus hypotonia. And these loser zones, this is pathognomonic for osteomalacia. Look at scapula, pubic rami, femoral neck, and ribs. How to tell them apart in the labs? Osteoporosis, osteomalacia, rickets. Calcium, normal. Osteomalacia, low or low normal. Rickets, same. Correct for albumin. Phosphate normal, osteomalacia low. Again, key to differentiate. Alkaline phosphatase, osteoporosis normal, osteomalacia high, and in Rickets, bone specific alkaline phosphatase is high from osteoblast. Parathyroid normal, high in secondary, unless there is hypopara, there is no change. Vitamin D normal, low in vitamin D different type, and only less than 20 is deficient. Urine calcium normal, here it is low and body is conserving, so you will not find any difference in the Rickets. DEXA T score, osteoporosis less than 2. In osteomalacia, there will be normal or low, and Rickets DEXA cannot distinguish quality. High alkaline phosphatase plus low phosphate plus bone pain, think osteomalacia until proven otherwise. So, when a patient is coming with bone pain, we will ask for calcium, alkaline phosphatase, phosphate. So, if it is low and alkaline phosphatase high plus bone pain, we will think for osteomalacia. Treatment: osteoporosis, calcium plus vitamin D. Anti-resorptive, biphosphonates, denosumab, anabolic, teriparatide. This is actually parathyroid hormone. And romosozumab if severe. And osteomalacia, vitamin D different type. Calcium until 1 to 2 gram per day until normocalcemic. Fixed cause. Rickets nutritional, same as osteomalacia. Higher calcium needs for growing bone. X-linked hypophosphatemic, phosphate, calcitriol. Now Furosemide is used, monitor growth. Deformities may need orthosurgery. Vitamin D intoxication warning: treating osteomalacia too aggressively leads to hypercalcemia. Recheck calcium after 1 month. Quick memory tricks. Osteoporosis is porous bone, too little bone. Osteomalacia means soft bones in adults. Rickets get rickety bored legs. Osteoporosis has normal labs. If alkaline phosphatase is high, it's not simple osteoporosis. So, alkaline phosphatase is very important. There is 2 sources of alkaline phosphatase, one from liver and one from bone. One is labile and one is heat labile and one is heat stable.